Okay, so I'm going to share my screen. Okay, and okay. 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 So we've only got a few guys on board, but that's all right. We're gonna record it. Okay. So Philip, can you hear me? Philip, can you hear me? I'll think. Okay, Philip's got no mic. Okay, that's right. You can just type some notes in, Philip, if you need to. Okay. So if this is a fairly interesting case. So Virginia, I'm going to get you to start.
She's class 2-ish in skeletal, but the molars, yeah, they're not badly out. She's missing a lower, well, probably both lower fives. The sevens are impacted, and it looks like she's missing.
Hold on a second. Hold on a second. If this was an oral exam, okay, we would go, how can you tell that we're missing both lower fives?
They're not there on the SEF.
No, yeah, well, the SEF's not going to tell you whether you're missing the both fives, okay? So
Okay, it's very radiolucent in the area of the lower fives, and it is not where the upper five is.
okay, well, we'll see in a second, okay? Right, but you okay? What else? How would you describe her profile?
It's retrognathic.
Yep. Retrognathic. What else? From a SEF.
Small jaw.
Yeah, small lower jaw. Yep. What else?
Very open.
Okay. So okay, let's just go back to some basics for a second. What are the 4 things that a SEF should tell you? If it's
sagittal relationship.
Yep, sagittal. Okay, so we're looking at a class 2 skeletal. What else?
Whether they're skeletally open or closed.
Yep. Okay, so the skeletal vertical. So how would you describe that?
Open.
Okay, so as in a dolichofacial type.
Yeah, very. Yeah.
Okay, good. Okay, and the position and of the upper and lower incisors. They're the 4 things that really a SEF should tell you. You can argue that a SEF can look at the soft tissue, but it's not really that accurate as the soft tissue profile.
She's very proclined.
She's very proclined. Yep. And Philip, you were right. You said she was dolichofacial. Okay. How would you describe her smile arc and her smile?
Quite nice.
Yep. Virginia, what are your thoughts?
I didn't hear what Jim said.
He said they were quite nice. The smile arc, position of the lower incisors. Sorry, the position of the upper incisors.
Yeah, if her face is level, it's possibly a little deep.
It could be a little deep, but so if let's say it is deep, right? Look, because we don't really know, where would you concentrate your attention on in opening the bite? Looking at that smile arc, what would you want to change the position of those upper incisors?
No.
It wouldn't be a priority.
No, not at all. You could increase the width of the buccal corridors a little bit. That wouldn't be a disadvantage. But from the point of view of running through of the smile arc, running around the curvature of the lower lip, it looks very nice. Okay, so let's look at her. Okay, so here's a buccal relationship. So Virginia, what has Adam done here? Hold a second. Okay, sorry, I'm wrong. Okay, So, okay. So describe her buccal relationship.
It's class 2. The canines are a unit, 1 unit class 2.
Yeah. Okay. So the canines are a one unit class 2. Okay.
On the right side, on the left side, no, half a unit.
Yeah. Okay. So half a unit class 2, a full unit class 2 on the right. Okay. And we've still got the lower E's present. Correct.
Yep.
Okay.
And the upper E's.
There is too.
And the upper E's. Okay. And from the Ceph, we would say her upper incisors are a little bit proclined. Clinically, it doesn't look that bad, but they are definitely a bit proclined. We would agree.
Yeah.
Correct?
Yep.
She doesn't really occlude terribly well at the moment either, and she appears from her tongue position to be using a tongue thrust to get a seal.
Yeah, but most patients who have because this is what you probably in some ways call it incomplete overbite, because she doesn't actually have contact of the anterior teeth. Most patients have to have a tongue thrust to form an intraoral seal. So there's a lot of controversy over, is a tongue thrust the cause or the effect of the problem? Is it the chicken or the egg? Okay, and probably 5% of cases are what we call endogenous tongue thrust, where the tongue thrust is actually the cause of the problem. 95% of cases, once you close the open bite and get contact, the tongue thrust disappears. The problem is you can't predict which is which. Okay, so that's a clinical problem that you have. So, but let's go on a bit further for a second. So we're missing the lower 5s. Okay, and we've got the upper E's present and the upper 5s.
Mm-hmm.
Okay. So tell me your treatment approach or your possible options.
Surgery on the lower jaw.
Okay, surgery on the lower jaw is one option. Okay. Okay, so we'll get to that. We'll get to that option later on and talk about how would you do surgery on the lower jaw if you were going to do it. Okay, because that opens up a whole interesting discussion in itself. Okay. What other options are there? And you need to think outside of the box here.
In the immediate, she probably needs those upper E's extracted to encourage the 5s to come down.
Maybe.
Because that looked like they were not coming down.
Okay.
Well positioned.
So she's got 2 missing teeth on the lower arch. Okay.
Mm-hmm.
What are you going to do with those? Okay, she's a class 2 patient to start off with. So let's just talk for a second. She's not having surgery.
Okay. If you took those E's out, then let those molars come forward.
Well, okay. If you let those molars come forwards at all, right? What you're asking now, Jim, is a minimum anchorage approach, because the last thing you want in a class 2 patient is to move those lower anterior teeth back.
Yeah.
Okay, so you are talking now, taking out the lower E's, moving the 6s 10, 11 millimeters forwards, because these E's are bigger than what a 4 would be.
Wouldn't it be better just to move them maybe 3 millimeters forward and maintain the space to put implants in when she stops growing?
That's a possibility. Okay, so how would you move them 3 millimeters forwards? Okay, let's say you were going to do this. Okay, how would you be able to move these 3 millimeters forwards and maintain it? Yeah, because if you took out, so 2 questions here, Virginia. Okay, if you take out the lower E's, what's the downside to that?
The fact that you'll actually potentially get tipping of the 6s as the 7s erupt, that the anterior segment is more likely to retract than the 6s moving forward because they've got good big roots on them.
And from a restorative point of view,
you've committed her to implants.
Okay, Well, you're probably going to community implants anyway, right?
Yeah.
Okay. But okay, what's the advantage of leaving the E's in place at this particular point?
Well, they act as natural space maintainers. And
And
I mean, one of the things I think that you've spoken about before is opening the contacts of the E's so that you can actually reduce their dimensions, and then they act as a space maintainer, but they're more close to the size of the space of the implant that you'd require.
okay, well, we're going to get onto that in a second, okay? And you're totally correct. But prior to that point, the question is, why do you want to keep the E's in present? Which is right from the space maintenance point of view, but what other advantage does it give you?
A slightly happier child not having extractions?
I don't care about happiness. Jim?
I don't know, just that it maintains the arch length.
Yeah, well, I'm thinking now as a restorative dentist, what would be the biggest problem if you took out that E? What's going to happen to the bone?
It'll disappear.
It'll disappear. So this kid's what, 13 or whatever it be? When would you be looking at putting the implants in place?
No sooner than about 17 if she's a girl, or when she ceases growing.
Yeah, okay. So you've got 4 or 5 years of no tooth there and just losing bone. So the longer you can leave that E in place in normal circumstances, because what you need is something there to maintain the stimulus of the bone. So one option is to trim down the mesial and distal of the E's, right, to a diameter of 7 millimeters, and then you're just going to close that amount of space only, and you're going to leave the E's in place for 6 or 7. Yeah, so the width is 7 millimeters. So once that E exfoliates, then you can put the implant in, and the bone is basically maintained, provided that E is not ankylosed. Because if it is ankylosed, it's not having the vertical eruption which maintains the bone.
At this stage, they don't look ankylosed.
No, they don't at all. Okay. Okay, so that's one aspect. Okay, so in the upper arch, okay, in the upper arch, how are we going to correct the overjet? How are we going to correct the overjet? Okay, so Philip suggested the upper first premolar extractions, okay, which is the traditional approach that people would take. Okay, we're going to take out the upper fours. Now, you take out the upper fours, and I'm not disagreeing with what you're saying at all, Philip. You've now got a 5 that needs to come down. Okay,
and doesn't necessarily look like it's in a very good position. You know, one of them's rotated.
It rotated, so you probably wouldn't start this patient for a fair while if you were going to take out the upper fours, because you'd be waiting for the 5s to come down. Okay?
Couldn't you send it to the surgeon and get the E's and the 5s out at the same time?
A possibility. So, because what you're talking about now is we need to take out and I think this is what I want you to start thinking about in your class 2 patients. It's not just to think that you're taking out upper fours, okay, always, but yes, if it's a class 2, you need to take out a dental unit on each side, okay? Now that dental unit could be an upper 5, could be an upper lateral sometimes, but you need a dental unit, okay? Okay, and you might change the type of teeth you're going to remove based on anchorage requirements, which we're going to talk about more in Module 6. But in principle, we're talking about taking out a dental unit. So if you wanted to start this patient now, because this patient's 13 or 14, you would go ahead and maybe take out the 5 and the E.
And the 8?
You could that's not a bad idea if the patient's having a GA, which more than likely they're going to. Because that way you can get rid of the 8s at the same time.
Would you also ask them to expose the 7s?
Probably not. But yeah, it wouldn't be wrong to do that. There's nothing wrong, but I probably minimise the surgery.
Mm.
I mean, having said that, it's pretty major surgery anyway. Okay, so Jim, are you on board with that approach?
Yeah, well, I thought after our discussions last week, you didn't want to take the fives out because
It depends on the anchorage approach. Okay, right. So in other words, if that was a maximum anchorage case, I would try to avoid taking out the upper fives. Okay. However, there is a difference in this case. Okay, Jim, a very subtle difference. And what's the subtle difference?
I'm not sure.
Okay, because when I say take out the upper fives, you've got about 7 millimeters of space, right? Okay, but we've actually got the upper E's here, which is about 10 millimeters of space. So it's not just the upper five, it's the upper E's which are there. So we can afford to lose a little bit more anchorage because we've got 10 millimeters of space to deal with, not just 7.
But then you've got to pull that whole anterior unit back.
Absolutely, but we're more likely to lose the upper anchor, lose some space with this space being lost. Okay, so let's just go back to you got a full class 2 on this right hand side, okay, and a 50% class 2 on the left hand side, okay. So on your right hand side, you want about 6 to 7 millimeters of retraction, correct?
Yeah, a lot.
Yeah, okay. Now, if you took out your upper fives and you've got 7 millimeters of space here, right, you're more likely to lose some of that space with the 6 coming forwards, correct? When you've got 10 millimeters of space, well, that's fine. You can lose about 2 or 3 millimeters. Does that make sense?
Yeah, it does.
Yeah.
Okay.
Unpredictable though, isn't it?
Oh, absolutely. So you would have to treat this as a maximum anchorage case.
So palatal bar and
You got it. Okay.
hang on to the 7s and
Yeah. Okay. So we'll talk about that in a second. Okay. That's the traditional approach. Okay. Now this patient went off to another orthodontist, and the other orthodontist said, well, why don't we go ahead and transplant these fives into these fives that we're going to remove into the lower E spaces. What do you think? They're going to have surgery to take out the upper E's and the upper fives.
Probably a good idea.
Jim, what are your thoughts?
I don't know much about transplants.
Okay.
I would implant to be a lot more predictable when she's growing up.
Okay. An implant would be a lot more predictable. Okay. This person. Okay. Well, let me go back a stage. They actually never went to another orthodontist. Okay. They've gone to other orthodontists who talked about taking out upper fours, etc. I was the one who said, why don't we do a transplant in the lower 5 spot? Okay. They're having significant surgery to remove the E and the upper fives. So what would be if you put the implant, if you put the 5 into the E space right here. Now this is probably not the ideal case, okay, but the roots aren't that great on the E's, okay, so they could exfoliate a lot earlier. So if the transplant works, okay, they would not need any implants.
Worst case scenario is that they've only been committed to the implants that we're going to have anyway.
That's exactly right. And if it works, they don't need any implants at all. And I've done cases where I've actually removed the upper 8s and put them into the lower 5 spots.
Those ones are pretty big.
Yeah, but you can actually rotate them. So you rotate them like, I think 180 degrees or whatever it be. 90 degrees, whatever it is, you would rotate them and you get the right mesiodistal dimension. Now the key to a transplant and we actually talked about this in module 3 in the early treatment module. The key to the transplant. Do you remember the old days when we were at uni and they talked about, oh, you can't impacted canines and you can't transplant impacted canines? The reason why they always failed was the apex had already formed. So the transplants work very well when the apex is open. And there was a guy called Bjorn Zachrisson who did studies over 40 years of transplants. And you know what he did, I think, 350 of these transplants. Do you know what his success rate was, Jim?
No, you're going to shock me. I don't know, 98%.
It was 97%.
There you go.
Okay, which was actually higher than what implants were for many, many years. Okay, but that requires a good surgical technique. You can't touch the periodontal ligament, all these other factors. Okay, so they had a very stringent surgical protocol. So I've done about 20 of these transplant cases. The key though is you want to see them early, because if those fives had already been erupted, the apex would already have formed, and the transplant won't work. So this is one of the reasons why you want to see these kids early. And so when I look at a case like this, okay, and I've got missing teeth, the first thing I'm doing is I pretend all the teeth are present, okay, and I say to myself, if all the permanent teeth are present, is this a black or white non-extraction case, a black or white extraction case, or is it a grey area? Okay, if it's a black or white non-extraction case, right, like in a class 2 patient, it's black and white to me that you don't extract the lower arch if you can avoid it. Okay, so to me, I would not be just because we're missing teeth, I would not be closing all of those spaces. Okay, if it's in the grey area, because it's crowded, etc., I may consider closing spaces. Okay. The upper arch is, to me, a black and white extraction case in the upper arch. So now I've got to decide which teeth do I remove. Okay. Does that make sense, the thought process?
Yeah.
Yeah.
Okay. So here we are. And so I've got the transpalatal bar in for added anchorage. Okay. I've got my brackets on. I've got colours on because the patient wanted colours. And these are the self-ligation brackets. But this is going back, I think this was 2003 if I did this case, okay? And I didn't use the double 14 night eye wires, which I would have done today, okay? And you can see how I've got some tubing over the wires here, okay? That's purely for protection of the lips, that's all that, or the cheeks, that's all that is, okay? So we've got, that would be an 014 night eye that we would have used. We bonded them up. Back then I wasn't using bite turbos very often, and I probably would have been using some bite turbos today. So here are the photos. So I've taken out the upper 5s and the upper E's, and I've now transplanted these in the lower arch. Okay.
When you band them up like that, that splints them, does it?
Yeah, yeah. So the first thing though, when the surgeon does the transplant, they've got to be out of occlusion, okay? Because they're very, very mobile, okay? So you've got to have bite turbos on, or the surgeon doesn't put, he makes sure that he puts them a little bit further down in the cavity area, so that there's no occlusion. If they were in occlusion, they would end up with hyperocclusion, and we would lose that tooth very quickly.
Mm.
Okay, and then we put some brackets on those teeth, and you're right, they act as a splint. But not only that, there is going to be some orthodontic movement, so it's got to be a very light force in the early days. Okay.
On the upper, Jeff, is that a wound dressing or something that she's got there on the left side?
Yeah, that'll probably be, I would imagine, just an Alba-Gel pack or whatever it be. I've got no idea, but that's just a wound dressing from the. Okay.
Yep.
So here now, we've lost a bracket at the time of the surgery on that upper left, upper right 4. Okay, so 12th of February. Oh, so we did this in 2010. Okay. I thought it was earlier than that. Okay. So here we are, braces on. So now all we're going to do is treat this as if it was an upper premolar extraction case, making sure that we look at the anchorage requirements in the upper arch, and our aim for our critical path to success is a class 1 canine. That's really the key now, okay? And we've just got to be very careful of these premolars. Now, theoretically, when Zafranson did his studies, he found that only about 10% required endodontic therapy. Because once again, if you've got a nice open apex when you do the transplant, you've got a really good blood supply to that tooth. It's when the apex is closed that you get the root resorption occurring, okay? So you want the apex to be very open. The hard part here is finding surgeons who are going to do it for you, okay? And I only know of 2 surgeons in Australia that have done this, okay? One was the surgeon that I was using, Peter Allen, at the time, and the other was Andrew Higgy, who's done a lot of cases with an orthodontist called Paul Schneider, who now is in charge of Melbourne University. But and I'm sure there are other guys around. I just don't happen to know them. Okay. So here we are. The rest is all just now very straightforward. So in March, we've rebonded the bracket. We're aligning the teeth, and I've got I've got this upper right canine nearly back to class 1. So I've actually removed the transpalatal bar, okay? Because I can afford now that I can lose some more anchorage on that upper right molar. Does that make sense?
Yeah.
How to get them back? The elastics. So.
Yeah, just elastic. Just some power chain elastics, some drifting back. You've got to have a look at the space that's been closed up on this upper right side. Remember, that was about 10 millimeters when we first started, because it was an E that was present.
And what wire you got there, like 2020 or something?
Yeah, this will be a 2020. This will be a 2020 wire in the upper, and the lower probably an 018 nitride, because I'm really slowing down the movements of the lower because of the transplanted teeth.
Okay, so isn't that going to be too flexible though, like to be using elastics to do that amount of movement?
Yes and no, but
like pulling overwrapping the 6 and stuff.
No. Yeah, look, the overruption of the 6. We remember I had a transpalatal bar in place at the time. So when I was using that power chain, I actually had a transpalatal bar in place, and that would have made
back to the 6, did it?
Yeah.
So isn't that going to pull the 6 forward as well? Like
yeah, but once again, the transpalatal bar that was there, and I was just checking on the anchorage requirements, because if I felt that I was losing anchorage, I would have stopped the power chain and just started running more class 2 elastics.
The transpalatal bar will stop it rotating on the palatal root, won't it?
Yeah, yes, but as I'm going to talk to you about module 6, when you finish with a class 2 molar relationship, you actually don't want this nice rotation of the molar. You actually want the molar to be rotated in a little bit. It sits a lot better.
Yeah.
Okay. So in a class 2 molar finish, which you would do in like an upper premolar extraction case, okay, in an upper premolar extraction case, you want it to rotate a little bit mesial to the palatal, okay, which it naturally does with the force system that you use with the power chain. Okay, but you don't want to overdo it. Does that make sense?
Yeah. Yep.
Okay. Phillips asked, did you activate and expand the transpalatal bar slightly? I probably did. Okay, so I probably expanded the transpalatal bar, but we're going to go through this more in module 7 with you guys, because when I expand that transpalatal bar, so if I make that transpalatal bar wider, so then I've got to actually squeeze it in, what's going to happen to the molars as well? Not only is it going to expand, what else is going to happen?
Push the roots into the cortical bone a bit? Or?
Probably the other way. It'll probably tip, because I've now got a horizontal force on the palatal, which is going to tip the crowns out to the buckle.
Yeah, that's what I meant.
Yeah, okay. Well,
a bit more anchorage too, doesn't it?
well, not really, because no, quite the opposite, I think, Jim, because the cortical bone is here on the buckle, correct?
And a bit on the palate.
I had a bit on the palate, I suppose. But when people talk about cortical anchorage, they want to try and put the roots more to the buckle.
Okay.
Yeah. When you talk about the intrusion arches that you would use in POS.
Mm.
Well, how do you bend that to get the roots more in the cortical bone? You get the roots more to the buckle, don't you?
Look, I can't remember.
Yeah. Well, no, traditional orthodontics, that's what you would tend to do, which means that not only do you have to expand it, but you have to add buckle root torque to the transpalatal bar as well. Okay, so it just doesn't tip out, but it moves out in a more bodily fashion. Because that way you're moving the root out with the torque, and you're moving the crown out with the expansion process. But we're going to go through all of that in module 7. Okay, when we talk about management of open bites, etc. Okay. So
when you start engaging the lower lower fives more seriously, is that do you take PAs and things to look at root formation, or?
Absolutely. Yep. And speaking of which, so here we are at this particular stage, and I'm seeing a significant root proximity problem on this lower left 5 now. And somebody was saying about tipping of the molars, look how that upper left molar has tipped across. What's interesting is the upper right molar hasn't tipped as much. Okay.
So do you shift the bracket on then the 3-5?
Yep. Well, but before I do that, I'm going to check clinically. Is it exactly? Yeah, because that's what it looks like on the OPG. Remember, back then we didn't have cone beams, and the more I've been doing orthodontics, the more I'm saying to myself, I don't believe that the OPG is that accurate for root positioning, and I'll show you in a second. Phillips asked the question, was a power chain used to close the upper 5 space from upper 6 to 6? Yes, it was at the time. Yep. Okay. Tell me, what do you think of that upper right lateral? Do you reckon it's mesially inclined or distally inclined?
Mesially inclined.
Okay.
Yeah.
Okay. What do you reckon about that lower left 5 or lower left 4?
Oh, upright, isn't it?
And what do you reckon about that lower left 5?
Distal.
I think it's distally tipped, but I'd like to see a PA rather than the OPG.
Yeah. Okay. Well, have a look at this upper right too, because this is the issue I see all the time. It drives me nuts. So this is the OPG of the upper right 2, which everybody thought was mesially inclined. So you look at that OPG and you start to change bracket positioning. You're going to make that even more mesially inclined, aren't you?
Yep.
From a clinical perspective. So so I think we either have to start to look at cone beams more often, okay, or we have to go by our clinical judgment. Okay. So it's interesting. So I did re-bracket that lower left 5. Okay. I did re-bracket that lower left 5. I've got power chain. So here we are. Okay, this is where we're at. Okay. So now I'm in a stainless steel wire. I'm in a 20 square in the lower. I'm just leveling the lining. I'm nearly there on the left side with it for a class 1. I'm nearly there on the right side with the class 1, and I've still got some spaces left over. So I can run some class 2 elastics, and I'm pretty good. I'm a little bit asymmetric, so I might end up running some class 2 elastics more on the left than I do on the right. So I might wear them on the left 24 hours a day, and on the right just at night time. Okay. So here, and I'm closing the space. That's not looking too bad. I'm class 1. I've got a bit of an open bite developing here, and I think Philip's question was probably very appropriate I probably should have done more expansion on those upper molars.
Why does the bite open there on the left?
You know what? I've got no idea. But the bite was always a bit more open, and I reckon that's probably a bracket. See where my bracket is on the 5.
Oh, yeah.
I reckon that should be more gingival. I reckon that's more of a bracket positioning problem.
So you just put some vertical elastics on that when you go to finishing wire, would you?
I would do. The only problem at the moment is what I'm seeing is see how that's tipped in lingually.
Yeah.
Jeff, is it possible for you to move the little window where you appear, because it's actually right over that slide?
Is that better or not?
Well,
Well, maybe I can move it in mine.
Yeah, I think you might be able to move it.
Yeah, I've just realised it. That's why I could never see that side.
Okay. Yeah, because my picture's on my third screen here, so that's why I don't. Okay. So
Yeah.
Okay, so Jim, good question from that point of view. See how it's tipping a little bit lingually? Okay. What would happen if I went ahead and put vertical elastics on?
worsen it.
Yeah. So
Yeah.
so what else could you do?
Or put a button on the palatal side and pull it.
Yep, exactly. So you could bond a button on the palatal of the 2.5, and ideally you would have a little pleat on the if you had a band on the 2.6, or you just take that band off, put a button on, and you run cross arch elastics. So from the 6.5 from the palatal to the lower 6.5 to the buccal, and so that'll give you an extrusive force and to bring out that posterior segment. What else can I see wrong in this picture?
3.5 still doesn't look right.
The clip's not closed on the 3.5. See that clip that's open?
Mm.
So I or my hygienist actually forgot to engage it. Okay? So this is one of the great values of photos, is especially if you've got your auxiliary staff doing it, or you've done it, you can go back and look at that. And I've had cases where my hygienist have forgotten to tie, they've tied in the upper wire and they forgot to tie in the lower wire. I know it sounds ridiculous, but it's happened to me. So Philip's asked a question, I thought using chain will deepen the bite, or is it predominantly opened by the torque in the wire? And Philip, you're totally correct. Yeah, usually closing the bite, usually closing spaces is going to deepen the bite, okay? And by having torque in the wire, and we can put some accentuated curve of speed at the same time, and that's what we would have done. So in this particular case, and once again, we'll do that in module 6, we will add some curve of speed to that 1925 stainless steel wire to counteract that deepening of the bite effect. Okay, so but what I would normally do is I would start off with the power chain on 1925 stainless steel, see how I go. If the bite starts to deepen, I would take that out, and then I would put in the upper 1925 stainless with a accentuated curve of speed. Unless that bite was really deep to start off with, and then I would obviously be opening up the bite first before I start doing the retraction. And we're going to go through that in the next module, because one of the principles in orthodontics is you've got to open the bite before you fix the overjet. And that's a very important principle, okay? Phillips asked, explain where I put the crimpable stops. I basically just put the crimpable stops distal to any teeth there, just to stop the wire from sliding around. That's all the crimpable stops are designed for, okay? And because when you're using self-ligation brackets, there's less friction in these self-ligation brackets, so the wire can really slide around a lot more. So these stops are just designed to stop the wire from sliding around. But an important point you raised. So for example, in your upper arch, let's say you've got some spaces. If you put a stop right up against the canine here, okay, that wire is supposed to slide back to close spaces. If you put your stop right up against the canine, the wire can't slide, can't go back. So you want to put the stop just distal to the lateral. You can put it right distal to the canine, because that way the wire can slide all the way back until that stop hits the next bracket. Okay, so it's important that you put the stops in the right area, but basically as a rule of thumb, if you put the stops distal to a tooth, it allows on each side so the wire can't slide around, but also it can slide back to allow space closure to occur. Does that make sense?
Yeah.
Yep.
Okay, so here we are. So we've still got a bit of a crossbite. I really haven't resolved this issue as much as I should have. So here we are in October 2011. We started about February 2010. Okay, now these molars need to be rotated more mesial in because of the class 2 situation. It will, and the other reason why we do that, remember when we rotate a molar mesio to the buccal, we gain 2 or 3 millimeters of extra space. In these patients, we actually want to lose a little bit of space, don't we?
So keep them rotated.
Yeah, so you tend to keep them rotated. So, Jim, do you remember in your POS, you would have had a prescription for a molar for a class 2? And it would have had
distal or something, wasn't it?
Yeah, yeah, and that's the reason. So this molar is not too bad. This molar needs to rotate more mesial to the palatal.
Would you do that by, if you did want to correct that, by banding up the 7 and connecting that?
That would probably help. That would probably help. But I think it's an issue with the prescription on our molar tube here. Okay, because back in those days we used to use a very high rotated molar, which is great for class 1s, but not great for this type of situation. Okay.
We've got a meeting coming up, mate, so I'm going to have to...
Okay, well, we're just about to finish. So just wait one sec. So this is basically our finished result. So just have a look at this. And we've got the lower 5s in place, and they've been stable now for nearly 10 years.
Awesome.
So it gives you, it's a great learning exercise, and later on I'd love to go through with you. Okay, if you were doing surgery for this case, what extraction approach would you use, because it's totally different. But we might do that next week.
Yeah, that's good. We got one next Wednesday morning because we've got Melbourne that.
Yeah, we can do one next Wednesday morning. That should be. Yeah, but Melbourne's not. When's Melbourne?
Next week.
Yeah, Melbourne's next Thursday.
Thursday.
Yeah, so yeah. Well, to be honest, I don't know whether. But
Because I've got to go to the airport that afternoon. So.
Up to you guys. Do you want to do one next week, or just because you've got a treatment planning session that we're going to do in Melbourne that you guys have
I
to.
think we've probably got enough homework to do between now and then.
Okay, well, how about we cancel next week then?
All right, that's good.
Okay, perfect. Okay, guys, we'll cancel next week. Okay. I'm going to just answer a couple of questions for Philip then. Okay. Okay, Jim, we'll see you guys next week.
Yeah. Cheers, mate.
See you then.
Okay. See you guys.
Thanks, Jeff.
Okay. Bye. Okay, so Philip, why do the lower 6s look more rotated compared to the upper 6s, compared to the 7s? That's a very good question, and I can't answer that question, but I probably should have. Yeah, they do, don't they? Yeah, and once again, I reckon that's once again due to the bracket prescription. And let's have a look at the OPG. The OPG doesn't look too bad. Yeah, I think we should have re-bracketed. I think the prescription we were using back then had too much mesial out rotation. Okay. Yeah, I think I've explained about the crimpable stops. Okay, I hope you enjoyed that case, and I think it's very, very interesting. So, and we'll see you in about 2 weeks. Thanks, guys. Bye. Keith, do I ever use?